welcome to the MedEClasses PG lecture series in which we will be talking about a very important and interesting topic of DSD. And this is something which is extremely common, extremely important, and has got huge implications in terms of evaluation and management. So, Dr. Vibha, why do you think DSD is one of the most enigmatic part that we deal in pediatric endocrinology? What are the challenges that are there in terms of evaluation?
So first of all, the identification whether there is a DSD or not, because some of the DSD mimics may cause confusion, and one of the most important consideration is the excess DSD, which is 21 hydroxyl and which is a life-threatening condition. So identification of excess DSD in an early stage is very important to prevent the grave consequences. So in these scenarios, this is important to identify the DSD at the right time.
And what are the common forms of DSD that you encounter in our clinical practice?
The most common that we encountered in OPD is 21 hydroxylase, and the in pubertal age group aromatase deficiency, and rare form of 11 hydroxylase, rarely we do get.
And of course, XYDSD is one of the ones which are
XYDSD, yes,
very
sir, definitely
challenging.
in the boys, XYDSD, 17 beta HSD, and 5 alpha reductase we do
So
have.
XY is something which is often very challenging to diagnose and much more difficult. XS seems to be important because of clinical relevance. So both spectrum becomes important. So what we'll do is that over the next hour or so, we're going to discuss about the pathophysiology, the etiology, evaluation and management of DSD. And at the end, we will have objective structured questions which will be done by Dr. Nimisha. So we'll start off about DSD. And DSD is something which is extremely important to identify, as discussed by Dr. Vibha, because there are lots of implications. So we'll talk about two cases where the diagnosis made a big difference. So we had a 1-month-old boy, child with DSD, who was referred to us with Prader stage 4. And what really happened was there were classical features of XY-DSD. Now, this individual had been given testosterone, 3 doses, and people thought that this is XYDSD. We have done our picture and then we'll go for surgery. But unfortunately, despite the various increase and everything happened, 5 years later developed renal failure. So what's very important to understand is that our job is not just done by identifying a DSD or giving some cosmetic measure. We also have to think of a serious underlying disorder, which could be something like a WT1 defect, which can result in renal failure. So a comprehensive evaluation of DSD therefore is extremely important. The second scenario was more of a diagnostic challenge, a day 3 child with DSD who again presented with Prader 4 with no gonad. So this looks like XX-DSD, and on further evaluation was found to have the Mullerian structures, and the karyotype was 46XX, again confirming. At that point of time, a borderline 17-OHP was identified, and based on that, a diagnosis of 21 hydroxylase deficiency was made, and the child was labeled for life in terms of treatment. Now, what happened by the treating physician was that they found that they could actually cut down on the dose of hydrocortisone, and the 17-OHP remained normal, which really excluded CAH as a possibility. If you look in retrospect, the amount of 17-OHP elevation was not remarkable, and this brought us to some alternate diagnosis. And when we evaluated, we found that there was delayed puberty. Now the child presented around 14 years of age with delayed puberty. On retrospect, there was a history of maternal virilization, giving a clue to aromatase deficiency. The key message is that if you identify XYDSD, don't just get satisfied with the diagnosis and treatment, think of an underlying cause. And not all XXDSDs are CAH. This is something which is extremely important to understand from that regards. All of you can go and have a look at our website learning.society.in, which has got multiple source courses and resources, including fellowship in pediatric endocrinology, our e-learning platform, the YouTube channel, which has got large number of information available. We have got courses which are available, and including fellowship and postgraduate programs which are there, which can be accessed online as well as on a hybrid mode. We run regular programs in the form of grand rounds, journal clubs, and PG lecture series. This lecture series is part of a 36 lecture series which aims to cover the entirety of pediatric endocrinology over a 3-year period. We have already conducted around 15 such lectures. They are all available on YouTube. You can go and have a look at that in detail in terms of that. There are multiple publications which provide coverage in terms of pediatric endocrinology, right from protocols to basic and to advanced pediatric endocrinology. Our latest application is now available on both Android and iOS store. It looks into entirety of pediatric endocrinology. So we'll talk about PG lecture series. I'll be joined by our consultant in pediatric endocrinology at Regency TDR, Dr. Vibha, who will be talking about etiology, and Dr. Nimisha, our fellow, will be talking about some very interesting cases.
We can classify the DSD broadly based on the basis of genetic composition, and it could be XX and XY. And in XX DSD, you don't have palpable gonads, but there is a presence of Mullerian structure, and it is mainly due to the androgen excess, which could be either be produced by the adrenals, and it includes the CH variants, 21 hydroxylase, 3 beta HSD, 11 hydroxylase, and the POR. And the androgen could be excessively produced by the ovary also in the cases of aromatase deficiency and in the cases of leutoma. Generally, in cases of leutoma, the excess of androgen is taken care by the placental 17 beta HSD, but when there is an excess of androgen and the 17 beta HSD is overwhelmed, then it causes the DSD in the XX female. The another category of excess DSD is due to the gonadal dysgenesis, which is due to the defect, which is due to the SRY deletion, defect in the SOX9 and defect in the FOXL2. And if we take the other arm, that is the XY DSD, which is characterized by the presence of palpable gonads, it means the gonads are producing AMH, and which prevents the development of Mullerian structure. So there will be no Mullerian structure and gonads will be palpable in XY DSD, and it is caused by the defect in the gonadal development. It could be either due to the defect in the NR5A1 gene, WT1 gene, and SRY deletion, and or due to the presence, gonads are present but they are not producing enough androgen, or the androgen are being produced but there is a resistance to the action, that is classified under the impaired DHT effect and includes star SCC3 beta HSD, 17 hydroxylase deficiency, 17 beta HSD, 5 alpha reductase, and the AIS. In the 5 alpha reductase, the androgen is being produced, but the testosterone is not being converted into the 5-DHT, which is the most potent androgen. And in the AIS, the testosterone is converted to DHT, but due to the resistance, due to the defect in the androgen receptor, it does not act. So it produces the XY-DSD and causes the AIS. Another important category is the sex chromosome, in which both the Mullerian structures and the gonads are present, and they can have testicular as well as the ovotestis. So starting from the steroidogenic defects and the excess DSD, the most important and most common cause in the excess DSD and when the excess androgen is being produced by the adrenals is the 21 hydroxylase deficiency, and it is the most life-threatening condition. They present with the early salt wasting, and they have a very high level of 17 OHP, that is more than 1000 nanogram per ml. The other variants are 11 hydroxylase deficiency. They present hypertension later on, but in the infancy they present with the mild salt wasting because the high DOC is not enough to prevent the salt wasting, but later on the requirement of aldosterone is reduced, so this increased DOC causes the hypertension and hypokalemic alkalosis. In this case, the 11 DOC is high. The next is 3 beta HSD, where there is a androgen is being produced but the level is quite low, so the male is not properly virilized, but it is it is sufficient enough to virilize the female, so we can have both XY and XXDSD. Presents with salt wasting, and there is a high level of 17 hydroxypregnenolone. The another important condition is a very interesting condition is the POR deficiency, where it is a basically electron donor defect. It affects the three enzymes, the 17-hydroxylase, 21-hydroxylase, and the aromatase. So it presents with mild salt wasting, and it has a mildly elevated 17-OHP, that is more than 30. The next important condition is the aromatase deficiency, in which this testosterone is not converted to estrogen, and it has a very peculiar history of maternal virilization. So starting with the most common and the most life-threatening condition, that is the 21-hydroxylase deficiency. Here there is a defect in the 21-hydroxylase gene, and there is a low cortisol, low mineralocorticoid levels, and a high androgen levels. It presents, there is a high androgen exposure in the prenatal period, which causes virilization in fetus, and it presents with pigmentation and early salt wasting. And here the diagnostic, we diagnose the case when there is a high level of 17-OHP and it is more than 1000 nanogram per ml. Coming to the next condition, that is the 11-hydroxylase deficiency. It is rarer than the 21-hydroxylase, and here there is a defect in the 11-hydroxylase enzyme. It presents with low cortisol level, but the DOC level is high, which causes the hypertension, and it manifested with the pigmentation, and as I already discussed, is present with mild salt wasting in the infant period, because the aldosterone requirement is high, the tubules are not mature enough, so there is a mild salt wasting in the infant, but later on when the aldosterone requirement goes down, presents with hypertension and hyperkalemic alkalosis, and in this condition the DOC levels are high. The 3-beta HSD deficiency, there is a peripheral androgen production which produces enough testosterone to causes virilization in the females, but not enough to cause proper virilization in the males, which causes XYDSD. And here there is a low cortisol and low mineralocorticoid. They manifest with salt wasting, and there is a high level of 17-hydroxypregnenolone and also the high level of DHEA. POR deficiency, as I already mentioned, that it is not an enzyme, it is basically a electron donor. So any defect in this electron donor will affect three enzymes, that is the 17-hydroxylase, 21-hydroxylase and the aromatase enzyme, and it presents with a history of maternal virilization. There will be mild salt wasting, and the 17-OHP will be high, but not higher as compared to the 21-hydroxylase. In the aromatase deficiency, the testosterone is not being converted to the estradiol, so there is a estrogen deficiency and a high level of androgen. They will present with maternal virilization, and the virilization will be present in the female infant also, and later on it will present with delayed puberty, and when we do the ultrasound, we will find multiple ovarian cysts in the ultrasound. As Sir has already mentioned, that the placental 17-beta HSD takes care of the entrance of the androgen and the estrogen from the mother to the fetus. So in the female fetus, it prevents the entrance of excess androgen to the female fetus. It prevents the virilization, but in the conditions like luteum of pregnancy and adrenal and ovarian lesions, when the androgen production is huge and the 17-beta HSD is not able to take care of this excess androgen, then it causes the XXDSD. And even in the cases when mother has the history of intake of danazol and still diethyl stilbestrol, it causes the XSDSD and XYDSD in boys, and it presents with maternal and fetal virilization, and it is a progressive condition. Now coming to the second arm, now coming to the excess gonadal dysgenesis, as a defect in the NR5A1 and the FOXL2, WNT4 and the RSPO defect in all these genes can cause excess gonadal dysgenesis, as FOXL2 and WNT4 and RSPO1 is required for the development of ovary, and NR5A1 is required for the bipotential gonad. So defect in any of the gene will present with XX gonadal dysgenesis and XSDSD. So coming to the next variant, that is the XY-DSD, and it can be broadly classified into the dysgenesis. This is mainly the defect in the gonadal development and the impaired DHT effect. So in the XY gonadal dysgenesis, mainly the 4 genes are important, that is the NR5A1, WT1, later on the SRY and the SOX9, and defect in any of these 4 genes will cause XY-DSD. If there is a defect in NR5A1, then the adrenal will also be affected because it is responsible for the adrenal development as well. When there is a defect in the WT1, it will affect the kidneys and it will present as the Denny-Drash syndrome, Frazier's, and the WAGR syndrome. And in the SRY gene, when there is a deletion in the SRY gene, it causes the reversal of the sex and there will be complete phenotype. Coming to the SOX9 defect, it along with the XY-DSD, it also presents with a skeletal dysplasia. And when there is a duplication of anti-testis genes, which are FOXL2 and DEX1, it causes XY-DSD. Coming to the gonadal dysgenesis, it is quite a wide spectrum term. It has a variable manifestation starting from the hypospadiasis to the complete female phenotype, and it depends how much the testis is damaged, and the extent, the more the testis is damaged, there is a more chances of malignancy. So in the milder cases, it presents with underviralization. In the partial cases where both the Sertoli and the Leydig cells are affected, then it presents with DSG. And in the complete gonadal dysgenesis, where there is no testis formed, it presents with where all the Sertoli, myoid, germ cells and the Leydig cells are affected, it presents with female phenotype. And as the damage of the testis increases, the risk of malignancy also increases from mild to the complete gonadal dysgenesis. Now starting from the SRY deletion, when there is a defect in the SRY gene, insertion in the SRY gene causes XX male, while the deletion in the SRY gene causes XY female. So there is a 10 to 20% of the cases of the XY gonadal dysgenesis are due to SRY deletion, and it manifested, there is a spectrum dependent on the extent of SRY defect. There could be complete ovarian development in a XY male, there could be over-testicular, and there could be complete testicular development, and the malignancy risk is quite high. Anorchia, it is a very interesting category. Anorchia means it is characterized by bilateral non-palpable gonads. We know the testes produce the AMH and they prevent the development of Mullerian structure. So the anorchia, the presence or absence of Mullerian structures depends, and the anorchia depends when the testis is damaged inside the during the fetal time. If the testes are damaged before the 8 weeks, then the Mullerian structures will be present and the testes will not be there. But when the testes are damaged after 8 weeks, then there will be no Mullerian structures. The testes, there will be low testosterone, and they will present like DSD. But when there is testes are damaged before 12 weeks, then they will present like a vanishing testis. There will be low testis, the penile size will be low, but there will be normal penis development. So coming to the anorchia, the most important consideration that we should keep in our mind when we have a child with bilateral non-palpable gonad is the XSGSD, and which includes the 21 hydroxylase deficiency, and identification of 21 hydroxylase deficiency is very important because it is a life-threatening condition, and management of this condition at a early period is very important to prevent the grave consequences. And another condition could be anarchia, or the testes are present but not in the scrotum, they are in the abdominal region. For the workup, the USG of the abdomen is required to look for the Mullerian structure. And AMH and the inhibin B levels become important to see whether the testes that are present in the abdomen or wherever they are functioning or not. And when we do not find any testes in the inguinal or the scrotal region, then definitely we should go for the laparoscopy to look for the abdominal testes, and if they are present, then we have to go for the laparoscopy exploration. Now coming to the persistent Mullerian duct syndrome, as the name suggests itself that the Mullerian ducts are present in these XY males. And what is the reason? It could be due to the defect in the AMH gene which causes AMH deficiency, or the AMH gene is intact, the AMH is being produced but it is not acting due to the resistance in the AMH receptor. So it presents with the presence of Mullerian structure, and the testes are undescended because of the presence of the Mullerian structure prevents the descent of the testes. It is because there is obstruction in the way of descent, so there are undescended testes. Now coming to the second category of which is impaired DHT effect, and starting from the proximal defects, which is defect in the DHC which causes Smith-Lemeli-Opitz syndrome. It has presents with low testosterone, syndactyly, upturnness, microcephaly. The second one is a side chain cleavage defect which presents with the adrenal lipoid hyperplasia. The adrenal size are quite large and they present with salt wasting. They present after 2 weeks and with a severe salt wasting. Another condition is 3 beta HSD. They also present with salt wasting, and they have both XX and XY DSD. The 17-hydroxylase deficiency presents with hypertension later in life. The 17-beta HSD presents with delayed puberty in females, while they presents with the wide spectrum in males depending upon the defect in the gene, starting from the hypospadiasis to the complete phenotype. In the 5-alpha reductase defect, the testosterone is not being converted to the DHT, so there is a XY DSD, and when the testosterone is being produced, but due to the resistance in the androgen receptor, it is not acting, so it presents with the partial AIS and complete AIS. In this partial AIS, there is a pubertal virilization, and the complete AIS also presents with the spinobulbar neurological condition. If we summarize the steroidogenic defect and the XY DSD, then starting from the 17 DHC, this DHC7, they present with syndactyly and salt wasting, and when we diagnose the condition, we will find that there is a low cholesterol levels. In the star and the SEC, they will present with salt wasting and all the metabolites will be low in this condition. In the 3-beta HSG, they will present with salt wasting and there will be high levels of 17-hydroxypregnenolone. In 17-hydroxylate deficiency, there will be hypertension, hyperkalemic alkalosis, high DOC level and 18 DOC levels. In the 17-beta HSG3, there is a complete reversal. There will be female phenotype in the male, and the androstenedione to testosterone ratio will be high because this androstenedione is not being converted to the testosterone. In the POR defect, there will be mild salt wasting, and the 17-OHP level will be slightly higher than the 20, more than 30, and the progesterone level will be high. In the insufficient androgen action, there are two conditions that causes the insufficient androgen action, and they are 5-alpha reductase deficiency and complete AIS. And if we compare these two, then the defect in the 5-alpha reductase is mainly the testosterone activation. It is not converted to this DHT, and in the complete AIS, the testosterone is being produced, but due to the resistance, it's not acting. The testosterone to DHT ratio in the 5-alpha reductase is more than 10, but it is less than 10 in complete AIS. We'll find pubertal virilization in 5-alpha reductase and increase in the feminization in complete AIS, which is during the puberty, we will be able to distinguish between the complete AIS and the 5-alpha reductase, because it is quite confusing condition to differentiate between 5-alpha reductase and partial AIS. Coming to the gender of pairing, the 5-alpha reductase patients are more reared as a male, but in the complete AIS they are reared as a female. The Mullerian structures are absent in both these conditions, and the patients of 5-alpha reductase deficiency are managed by the topical application of the DHT gel, while in the complete AIS, gonadectomy is done after puberty and there is a estrogen replacement. And coming to the very interesting condition, that is the sex chromosomal defect, where both the Mullerian structures and the gonads are present, and it could be due to XXY mosaicism. There is a defect in the post-zygotic era. Some of the cells will have X and some of the cells will have XY, that causes the DSD. And the presentation is variable, depends on how many cells have X and how many cells have XY. The gonads could be normal or dysgenetic testes, they could be normal or dysgenetic ovary, or they could be streak gonads. They present with the asymmetrical gonads. One side they will have testes or one side they will have ovary, and there is a high malignancy risk, and the cardiovascular risk is similar to as present in the Turner's syndrome because of this XY mosaicism. Now coming to the Y chimerism, it presents in a similar way as the XXY mosaicism, like they have normal or dysgenetic testes, they have normal or dysgenetic ovaries, and they could have streak gonads, but the defect is different. They have zygotic fusion, the two cells get combined and produce the defect. And the chromosome could be the combination of 40XX and 40XY. They present with asymmetrical gonads, and they have both Mullerian structures and testes, and for the management, gonadectomy has to be done in this condition. Now coming to the ovotesticular DSD, where we have both ovaries and testes. Ovaries are present in the one side along with the fallopian tube, and testes are present on the other side. The gonads, sometimes the gonads could be completely ovaries, sometimes the testes are completely developed, and sometimes there is ovaries and testes. And when we do the biopsy, we'll get the granulosa and the Sertoli cells in the biopsy, and there is a defect, there is a mosaicism which causes the ovotesticular DSD. And as we have somatic mosaicism in the Macune Albright, we have the gonadal mosaicism in the ovotesticular DSD. And for they have a very variable gender of pairing presence on the what gonads are present, whether it's testes or ovary. And for the management, we prefer to get the gonadectomy done.